is a clinician scientist and the Chief of Pathology and Laboratory Medicine at Mount Sinai Hospital, Toronto. So I've the fortune of working with her most days throughout the week. She's a professor in the Department of Laboratory Medicine Pathobiology and cross-appointed in the Department of Surgery, a member of the Institute of Biomaterials and Biomedical Engineering, and Director of Collaborative Program in Musculoskeletal Sciences at the University of Toronto. Fellow of Canadian Academy of Health Sciences, the Director of Bioengineering of Skeletal Muscle Team, which consists of a multidisciplinary group of investigators, including engineers, biologists, stem cell biologists, and clinicians, whose work focuses on regenerative medicine. She's on the Executive Committee of the Sarcoma Site Group, the Canadian Cancer Society Research Institute, and is the pathology representative for Cancer Care Ontario's Sarcoma Disease Site Group. Her research interest is in the bioengineering of tissues for articular cartilage repair and intervertebral disc replacement, and she is a Prim Chair of Osteoarthritis Research Society for the International 2014 World Congress of Osteoarthritis. And she is the editor and member of the editorial board of Osteoarthritis and Cartilage, and has published over 200 papers in multiple book chapters. So I keep going on with the accolades and accomplishments of her career. But I think without further ado, I welcome Rita to give the talk today.
Thank you very much, Aaron. I'm very pleased to be able to present an update on the CAP checklist as related to soft tissue and bone tumors. I'm going to start off with a disclosure, and I have nothing to disclose, at least not related to financial relationships, and I will not discuss off-label use in my presentation. Today, I thought I would cover 5 topics. The first 2 are related to soft tissue tumors. First, the handling of soft tissue tumors, because this is such a critical component of what we do. Secondly, to update you on the changes that have occurred in the most recent version of the CAP checklist. And thirdly, I thought that I would try and address any questions that I think you might have related to how to handle these tumors. Number 3, I wanted to update you on some of the changes that are slated to occur regarding the delivery of sarcoma services in the province. And then finally, very briefly, touch on bone sarcomas. Specimen handling. I'd just like to review this, not that I have to tell anybody online how critical proper specimen handling is to the quality of the diagnosis that we render, the development of treatment plans, and the prediction of outcome for these patients. I won't spend a lot of time on it, but I do think it's important to refresh everybody's memory about this. Handling of biopsies, clearly there's not really a lot to say, but if you're fortunate enough to get 2 or more biopsies from a patient, then we would recommend that you try and split those biopsies up. Of course, given the number of biopsies, try to ensure there are no more than 2 biopsies per cassette. We've all been in the position where we've started doing immunostains, and before we know it, we're through the block. It's really very helpful to be able to have a second block as a backup, of course, assuming that there's tumor in that second block. But to have a second block for backup really has gotten us out of a number of tight situations. So if you're fortunate enough to receive 2 or more biopsies, try and split them up as appropriate. Of the resection specimens really are probably no different than how we handle most tumor resection specimens, except for the parameters that are specific to soft tissue and bone tumors. If the specimen is handled appropriately, we should be able to confirm the biopsy diagnosis. That is necessary, actually, and I'll discuss that a bit later on, and to accurately grade the tumor, particularly if it's been a core biopsy. It will allow you to determine prognostic factors, because currently, tumor size and location are the best predictors of outcome at the present time for these patients. It allows you to guide treatment based on the adequacy of the margins and what's present at the margins. Sampling these tumors appropriately is really critical for these patients. Example, here's a resection specimen, a nice small one, and it is critical that the surgeon orient the specimen for you. And you can see in the upper image, we've got a short suture superior and a longer suture laterally. And this allows us to orient the specimen. And then comes our obligation to ensure that we have inked the margins. And on the lower panel, as you can see here, you can see the cutaneous tissue is all stained brown, and that's because it's been inked. It's very important for assessing our margins. Your description, like their tumor, requires a description of the overall specimen size. Importantly, the dimensions of the tumor in all three dimensions. And that is important because it ensures that you've got the largest size of the tumor measured. To note in your description where the tumor is located. Is it superficial? Is it deep? And it's also important to document its relationship to fascia. And I'll talk about this a bit more in detail. The thing we like to do is guesstimate the percent necrosis. The important features, the tumor size in all three dimensions, the distance of the tumor to all the 6 resection margins located, and its relationship to fascia are the really critical components of your description. So just as an example of what I'm talking about in terms of tumor location, right-hand side, you can see skin in the superficial aspect, and in this subcutaneous tissue, adipose tissue, you can see a tumor that is confined purely to the adipose tissue, and this is a superficial tumor. On the left-hand side, you can see the tumor here, and it's surrounded by muscle, and of course, I have to tell you, but that makes it a deep tumor when it's in muscle. Faced with tumors that are present in the adipose tissue and in muscle, and we assess those based on the involvement of muscle. So if we've got any component of the tumor in muscle, then it's considered a deep tumor. Just interest, tumors that are located in the thoracic region, the abdominal cavity, and the retroperitoneum are all considered deep. The other parameter that we assess is the relationship of the tumor to fascia. That for 2 reasons. Firstly, it helps us assess the depth or location of the tumor, and secondly, it's important for treatment. The reason it's important for treatment is that even though it's very thin, it's considered relatively impermeable to tumor penetration, and if it's negative, it's considered an adequate margin. If we histological sections from the tumor that we were just looking at, you can see on the left-hand side the tumor, the pseudocapsule, and variously you can see the fascial layer. think you can appreciate that the fascia is separate from that pseudocapsule here, where there's some adipose tissue, and then in this region, the tumor seems to be abutting the fascia. And look at these areas at higher magnification, as you can see here in the upper right-hand panel. You can see the tumor, the pseudocapsule, the separation from the fascia, as you can see here, by some loose connective tissue and adipose tissue. Please note you can see the inked margin. And you appreciate that this is not involving the fascia. And interestingly, when we go to that area of the tumor, which seems to be abutting the fascia, we can see at our magnification that the fascial layer is intact, and it really is just adherent to the fascia. It seems to be separate from the major part of the tumor, contiguous with the pseudocapsule. What was a particular case is that we look in this area, magnification, we identified occasional tumor cells percolating out from the main tumor mass, and perhaps inciting this reaction, we don't know for sure. But it does speak to the complexity of these tumors and how they behave and why it makes margins difficult to assess. But in this particular case, the main tumor, nor these isolated cells that we could see were infiltrating the fascial tube, and therefore this was considered a superficial tumor. If the tumor had been involving fascia, it would be considered deep. The fascia and muscle makes it a deep tumor. Next parameter we like to guesstimate is the extent of necrosis in the tumor. And I use the word guesstimate for a reason, and I'd like to just explain why in the next few slides. This superficial tumor, and you can see this area here, which appears to be necrotic. When we serially section this tumor, we can see areas, as you can see in the lower panel, in which tumor doesn't show obvious necrosis. And so it highlights the heterogeneity of these tumors and the need to serially section them and look at all the tissue section, all the slices to guesstimate this necrosis. If we section from the region where the arrow is, we histologically. There's definitely evidence of necrosis, as you can see in the lower panel, some tumor cells, but clearly tumor necrosis. And in another area, you can see the hemorrhage that we saw grossly, but you can also see tumor. The estimate of necrosis on gross examination is very difficult to do accurately. And to give you another example of this, this is another tumor which was a leiomyosarcoma and was treated with radiotherapy. We got the resection specimen, and this is a representative cross-section of that tumor. And in the checklist, it asks you to assess necrosis as a result of therapy, and in that they like you to evaluate it histologically and on your gross evaluation. So here's this tumor, and when we looked at it, we started to ask exactly where was the necrosis and what would we consider tumor in guesstimating. We know that that's gel foam, ignore that. We know that there's definitely areas of necrosis that look like they should be necrotic, areas of hemorrhage, but what area? Is this tumor is it fibrosis? Can work. And so as we sampled that area particularly and examined it histologically, and you can see that in the upper panel, and you can see is this diffuse fibrosis throughout this area. Under magnification, you can appreciate the fibrosis and the scattered inflammatory cells. So in this tumor section, there was no necrosis. Excuse me. And that's what I mean by guesstimating necrosis. It can be very difficult to do on gross examination. So how do we handle this? We adequately sample the tumor. And thumb is 1 section per centimeter up to about 12 sections. And of course, you are encouraged to take more sections if the tumor is heterogeneous in its appearance and you're concerned about different areas. Generally, 12 sections is appropriate. Recommendation to take 1 sample from an area of necrosis and calculate the transition from the necrosis to what you consider is viable tumor. The fascia, because we think that's important. And as always, we take representative sections from all 6 inked margins. And those margin samples are taken perpendicular to the section margin so that we know that we have orientation and visualization of our margin and can guess how close the tumor is to the resection margin, being into consideration the growth description and the shrinkage. Actually do this in practice. Here's our tumor again with the necrosis in another area which we don't really know what's going on. So we would take and we would take slab and sample the tumor in its entirety in the particular slab. And this ended up being 5 sections. While doing this, we were also able to get the fascia in sections, which helped to limit the number of sections as well. And the other thing we would do is take a representative section from the area that we thought was necrotic and transition with what we would consider viable tumor. How we would sample this tumor and hopefully address the issue of evaluating necrosis. Estimate the necrosis on the histological slides and take into account what we see in the what we consider as gross necrosis. Okay. So that's how we handle soft tissue tumors. Moving on to the changes in the CAP checklist for tumors of soft tissue. Haven't been a significant number of changes, and so there won't really be much change in your practice. The first change is that the histological classification has been updated to reflect the WHO classification that is published in the 4th edition, 2013. So now it matches up, which makes it a bit easier for us. The other change was in Table 1, which documents the cytogenetic molecular alterations or events that can occur in the tumors. And the chart has been updated. As you can imagine, as the field of genetic testing is not just increasing, it's exponentially expanding, it's a continually evolving field. This is out of date. So it's a good place to start. You should know that it is missing things and is missing alterations. And if you're truly interested, you have to go to the literature to be able to keep current. So it's a good guideline but it's not 100% up to date. Another change has been in the checkbox of treatment effect. In the current checklist, only required to complete that if it's applicable to the tumor. So the tumor hasn't been treated either with radiotherapy or chemotherapy. You check out that it's not applicable and you can move on. And the whole area of necrosis becomes moot, which makes it a bit easier. The necrosis that we have to assess on the gross appearance becomes moot. The fourth change has been in the grading. That really has been very minor, but I'd like to spend a few minutes on grading because, like sample handling, it is another very important part of our contribution to patient care and predicting prognosis. Very interesting topic. I should start off by saying that there really is no agreement amongst people who are interested in soft tissue and bone tumors as to the appropriate grading system to use. And there are many of them. But in the past few years, based on some of the literature and the CAP checklist and the JCC, the grade system, NCLCC, and I'm not going to say it all, has been accepted as the most favored grading system. And the one that's used in the CAP checklist, it's the one that we use and that is used across Ontario. The grade is determined by three features: the differentiation of the tumor, mitoses, the number of mitoses, and the extent of necrosis. So three features: differentiation, the number of mitoses, and the extent of necrosis. The change has been that the chart has been updated to more accurately reflect differentiation. So, principle is that you get 1 point if the tumor resembles normal tissue. For example, leiomyosarcoma, well-differentiated leiomyosarcoma, it would be scored 1. If the tumor type was certain, such as myxoid liposarcoma, you get 2 points. Everything else essentially gets 3 points. And there is also a chart provided in the CAP checklist that gives numbers for different types of tumors, and you can refer to them as a cheat sheet. To give you examples of the scoring, you can get a well-differentiated lipoma-like liposarcoma, as you can see on the left-hand side, is given for 1. You can see the adipocytes that resemble normal adipocytes. They're varying markedly in size. You see the presence of lipoblasts, obviously. This gets 1 point. Mixed liposarcoma, as you can see in the upper panel, in which it's almost a light microscopic diagnosis. In many occasions, you can see the vascular component. You can see the microcystic change with myxomatous matrix here, and you can see lipoblast. Not easy to see at this magnification, and the classical cells of the myxoid liposarcoma. That gets a score of 2. And score 3 is other things such as synovial sarcoma, as you can see here in this image. And this is a synovial sarcoma. In the middle clearly was a peripheral nerve sheath tumor. And I should mention that all of these tumors were confirmed by molecular analysis to to demonstrate the classical alterations associated with these diagnoses. And it just emphasizes the importance of molecular analysis in helping us arrive at the right diagnosis. A bit. We're talking about the scoring of these tumors. So score 1 looks similar to the tissue from normal tissue, which it resembles. 2, where the typing is relatively certain, and 3, pretty much everything else. Ammeter is mitoses, and we count mitoses 0.7 millimeters squared. And this is very important because you have to determine your field diameter to determine how many fields you need to count. On my microscope, 1.7 millimeters squared is actually 6 fields. In analysis, it might be 10. It's critical to determine what will give you 1.7 millimeters squared and count the mitoses in that area. It's easiest to do it at 400 times magnification. Sometimes we can be confused by lymphocytes looking when they're flattened, looking like mitotic figures. And should start from an area which you can see proliferation, where you can see some mitoses, in a sense a hot spot, and consecutive fields to allow you to count an area of 1.7 millimeters squared. It is divided depending on the number of mitoses, where 1 is up to 9, 2 is up to between 10 and 19, and then 3 is greater than 19 mitoses in that 1.7 millimeter squared area. The third feature with S is necrosis. Necrosis for grading is determined on the histological sections only. And there's no necrosis in your histology, it's 0, doesn't get anything. And then if it's less than 50, it gets 1, or greater than 50, it's 2. And you assess these on your histological sections available for review. And take those 3 scores, add up, and sum of those scores is the grade. So a tumor has a score of 2 or 3. 2 tumor has some score of 4 or 5, and a 3 tumor has some score of 6 to 8. And that's the grade of the tumor. And that's the French system. So that's how we fill in the CAP checklist for grading. Just points to draw your attention to in the synoptic reporting. At present, this is required for resection specimens. So biopsies are not required to be reported in a synoptic manner. However, I'd like to recommend that, if possible, you use a synoptic type format for these biopsies. The surgeons get trained in one way, and sometimes they you have to worry about them getting confused with different presentations. If it's more, if it's consistent, actually everybody concerned, not just the surgeons. Biopsy, and you want to fill in the size. It's appropriate to take it from the electronic medical record. The medical imaging report is appropriate surrogate for the size of the tumor. Mind you, we don't grade all tumors. They're subset and are listed on the CAP checklist. I'm not going to go through all of them. I've listed some examples: epithelioid sarcoma, clear cell sarcoma, malignant peripheral nerve sheath tumor. These are tumors we don't grade. There is a category for that on the checklist. You can grade recurrent tumors if you would like. the update and details about the changes in the CAP checklist. On to topic 3, and I try to think about some of the questions that you might have about sarcomas, and try to answer them in advance of your questions. So, in terms of processing these tumors, he talks about freezing tumors, and it was particularly true. Biobanking was important. I hate to say the old days because that would mean old, but in previous times. But our level of sophistication is increasing in terms of genetic testing. We find we can do almost all of our testing on paraffin-embedded tissue. So there is no need to take a sample of tissue and store it in a biobank. There may come a time when we want to do proteomic analysis, and the statement may change, but there's also a move to try and develop proteomic analyses on paraffin-embedded tissues too. And so I suspect that will come. But if you submit the tissue in paraffin, it is appropriate for all of the molecular studies we want to do, and we will plan to do as that library expands. Other techniques such as next-generation sequencing will be an integral part of our assessment of these tumors. We will likely be able to do them on paraffin-embedded tissue. And all the data to date suggests that that's possible. Issue thought might be of interest is the immunohistochemistry. And there's a lot of talk about how long biopsy should be ischemic, how long it should be in fixation. These issues have not been addressed, particularly for sarcomas in the way that they have been for breast biopsies. And so I would argue for common sense in this area. And ASCO guidelines suggest a minimum fixation time of 6 hours for biopsies, and between 48 and 72-hour time, depending on the particular antibody. So if you keep within that guideline, you should be okay, and that is something that we follow here at Sinai. The other question that I sometimes get asked is decalcification. And yes, it is actually very important how a sample is decalcified and for how long. And it turns out that decalcification has a very profound effect on histological features of a tumor if it's been over-decalcified. So we want to maximize the information that we get out from these bone biopsies or biopsies that have calcification in them. The time in calcification is critical, and how we decalcify it is critical. We have come across made the decision after checking multiple decalcification procedures upon the use of formic acid as our method of decalcification, and we use an 8% formic acid solution. We put in a shaker because that aids in the decalcification process. Speed up a bit because the time it's in that solution, the better they all are, and easier to test the histology. And we check the extent of decalcification by X-ray and in our X-ray machine. It is a bit labor-intensive, but it has really resulted in getting optimal morphology so that we can assess these tumors. The other feature we have found is that using this format, our antibodies will work on decalcified tissues. Some questions I thought you might have about processing, and of course I'm glad to answer any more. A question I wonder about is, what is the accuracy of these core biopsies? Core biopsy has really been a major advance in the diagnosis of tumors, really from a variety of perspectives. But are they sufficient to really assess these tumors? And particularly, given what we know, that these tumors can be very heterogeneous in their morphology and extent of necrosis. There have been a plethora of studies, and I won't go through all of them, but I thought I'd pull up one, which was a study done by Strauss in 2010, in which looked at core biopsies taken from 426 patients who had a soft tissue mass, compared the results of the core biopsy with the resection specimen results. And to demonstrate in these 426 biopsies is that the biopsy is accurate in distinguishing from malignant in 97% of the cases, a 95% chance of a negative predictive value of predicting that when it was negative, it was truly negative. So these biopsies are actually very good. They are not perfect, not 100% accurate, but they're very effective as a way for screening these patients and to decide benign from malignant. They're less effective in the typing of the tumors and really not predictive of outcome. And we actually did a study where we looked at 100 cases of core biopsies and we correlate that with outcome and demonstrate that they were really did not predict with metastasis or disease-free survival. And that's not surprising, considering the heterogeneity of these tumors and the limited amount of sampling. We know that if a tumor is a high grade on biopsy, it's likely to remain a high grade, but if it's low grade on biopsy, it could very well turn out to be a high grade. And to circumvent that, there has been literature to suggest that at least 4 core biopsies are required for appropriate assessment of these tumors. There's not a lot of literature on that, and we found that about 75% of our biopsies had about 4 cores. So core biopsies are a good way to assess benign versus malignant tumors. They're not 100% accurate, so the surgeon has to be aware that there could be changes on the resection specimen, and they have to know that grading of the tumor has to be done on samples that are more adequate in amount, and that's usually open biopsies or entire resection specimen. So we were able to show that the open biopsies were predictive of outcome. So open biopsy or the resection specimen if grading needs to be predicted. I also thought this might be an opportune time to discuss with you some of the changes that are occurring in terms of the sarcoma service delivery model in the province. I wanted to look at the delivery of sarcoma services in Ontario, given the complexity of the diagnostics, the imaging, treatment, and social supports that are required to handle these patients. Best to minimize use of the healthcare dollar and provide optimal patient care. You'll note the format's changed. I've asked Cancer Care Ontario to provide me with some slides that I can present to you today to describe what is occurring in Ontario. So, just as background, in 2009, CCO brought together a number of individuals, which they deemed an expert panel, who reviewed the literature, looked at patterns of practice in different countries and provinces, and the horizon, and recommendations for the organization and management of adult sarcoma patients in Ontario. And this doesn't apply to pediatrics. In December 2001, they put a call for proposals across the province, and proposals were then vetted by a steering committee, which included representatives from the clinical side of the practice and administration side of hospitals, as well as patient and family representatives and CC representatives, and made a recommendation for a provincial sarcoma services program. I'm not going to go over all the details, but just to expand on the areas that are particularly relevant to us in the pathology sector. The province will be served by 3 programs which will be multi-regional. Each program will have 1 host site and associated partner sites and partner regions. The end is that all patients will be diagnosed at the hospital, wherever that is across the province. Treatment will be referred, the treatment will be referred to the host site. Since it's a hub and spoke model where the host is the hub and the partner sites and partner regions are the spikes. And the partner sites can demand for very specific entities under the stewardship of the host site. So just to in words what I've just said, there are going to be 3 sites across the province: Hamilton, Duravinsky Cancer Centre. Toronto will be at Mount Sinai Hospital and will include the Princess Margaret Cancer Centre, which is the Ottawa Hospital Regional Cancer Centre. And those will be the 3 sites, the 3 host sites, which are sites to which patients will be referred. Sites. So Hamilton has 2 partner sites, Sudbury, Windsor Regional Cancer Program, and it has its associated partner regions. My hospital, the Toronto site, has 5 partner sites: Royal Vic, Thunder Bay, London, Grand River, Kingston General. Associated partner regions, and these are regions. Ottawa has no partner sites and has a partner region. And the sites were selected based on the fact that they were teaching hospitals and/or cancer centers. The intent is that patients will be at their hospital that is geographically closest to them, but treatment will be offered at the appropriate host site or partner where appropriate. And generally, to demonstrate what I've just said, you can see the host sites are in indicated in purple, Mount Sinai Hospital with its affiliation in Princess Margaret will host sites and partner regions covered in gray, and that includes Thunder Bay, which you can see here, will service the partner sites and partner regions in blue, which you can see here and here, and Ottawa, which you can see here, will be the site for the area indicated in green. Now, you do not have to refer your patient to your host site, but you have to refer the patient to one of the 3 host sites. You will refer it to the appropriate host site, but that is not a requirement. So the service delivery then is clearly defined, and each site or region, the host site, the partner region, have really defined what they can do and what they can't do. And it's all areas in the patient care, not just pathology. As you can see, there's criteria for imaging, for therapy, for chemotherapy, for surgery, for rehabilitation, components as well. Every area has been defined as to what they will be able to provide of care for the patient with a soft tissue or bone tumor. What's relevant to us here is particularly the surgery. I just want to draw your attention to the bone and soft tissue tumors. And look at the soft tissue because clearly that's the biggest bulk of what we do. You can see is that partner region will have a biopsy of the patient, review it with the pathologist, but not allowed to do surgery. These cases, together with the cases that came to the partner site, will be referred to the host site treatment. So for the region and the partner site, except for certain situations in site. So, for example, London will refer their cases to Toronto for the surgical resection, except for cases can be done according to the CCO criteria in London. So how does that in terms of pathology lab services delivery? Well, it has an interesting effect. The site will now be responsible for expert and secondary review of the tumors. So the biopsy was done in a partner region. The biopsy will then be sent to the sarcoma site, where it will receive a secondary review, or if the partner site felt comfortable signing it out, or if the partner site did not feel comfortable signing it out, could be shared for an expert opinion. If you want the case diagnosed or you can send it to the host site, and it will be sent to the host sarcoma site for secondary review because that's where the treatment's going to occur. Host site must be able to provide more extensive investigations, more extensive panel of immunohistochemical markers, access to electron microscopy if it's necessary, and we are using that much less these days, and more importantly, it must provide molecular diagnostics for all of these cases. The partner site, again, can do the initial review, actually do molecular testing if they so choose. But because the treatments in most cases will be at the host site, secondary review will occur at the host site. The secondary review is presentation of these cases at multidisciplinary case conferences. And site will host a weekly or biweekly, depending on how many cases they have, a MCC tumor board. All of these cases will be discussed, at least 10. The partner site should attend those conferences, and the partner region pathologists are encouraged to attend, but it's their decision. As you can imagine, work is just ongoing to try and figure out how all of this is going to happen. But importantly, it has been approved at the CEO level. It has not yet been approved at the ministry level. So say that all of these slides had confidential at the bottom of them because they have not yet been approved at the ministry level. The expectation is that it will be approved. I thought it was important that everybody be aware of this sooner than later, as we are, so we can plan for this. And I took off confidential because it didn't seem appropriate, considering that we're all sharing in this. So it's not happening today, and it's not happening tomorrow. The implementation date is yet to be identified, and there will be a lot of communication around that when it is approved. But this is the plan to maximize healthcare dollars for this complex tumor, which really is relatively rare. When you look at the numbers, it looks like we have 2 to 3 cases per 1,000 individuals. Relatively uncommon tumor. And it is an approach that is mimicking that done for lung cancers and neuroendocrine tumors. It's not as if sarcomas have been picked on for specific treatment. What's planned? You're probably wondering, as we were when all of this was developing, for this. Are we going to bill your hospital for the work that now comes to the host site for this extra work? And the answer is hopefully not. The plan is that this extra work will be covered by CO. Your hospital will not be billed for this activity. The host site, Hamilton and Ottawa in general, will be responsible for expert review, secondary review when there's treatment involved, and molecular diagnostics. The site can also do molecular, and all bodies done locally will be interpreted locally. So to the last aspect of my presentation, and suite, bone tumors. There's really been very little change to the Synoptic Report, but in reality, bone tumors will be referred to the host site. I have not mentioned that when I was showing you the surgery, but the intent is that bone tumors are even rarer than soft tissue tumors, require special processing capabilities to handle these big tumors and all the decalcification that's associated with it. and that all tumors will be sent to a host site for treatment. So that one is straightforward. Cases will all be referred to host sites. That ends all the areas I'd like to talk about. I'm sure that I haven't covered anything, and I haven't covered everything. And I am very glad to answer any questions you might have. Thank you very much.
Okay, I'm just waiting for questions. There's no questions that have come in so far, but we'll just win it.
Yeah. Thank you very much for giving that review. I was hoping you were going to mention the funding, because I know it comes up when it comes to the molecular testing, so that centers aren't afraid of referring and then receiving large bills, because of the immunohistochemistry and workup of these cancers can be quite expensive.
Absolutely. Yeah. We know firsthand. And it's interesting, as our appreciation of the genetic alterations that occur in these tumors continue to expand, some of that testing actually gets translated to the immunohistochemistry. And that, I think, speaks to the fact that actually the number of immunostains will only continue to grow, part and parcel of this expansion of the genetic testing, which is really increasing significantly. We found that our appreciation of the headache in the morphological features of some of these sarcomas, we use genetic abnormality as our criteria, is really a little bit broader, I think, than many of us appreciated. And we're seeing more and more papers of the range of morphologies that one might see in a myxoid liposarcoma, for example, which genetic testing we might have been reticent to call a myxoid liposarcoma. So it's an interesting time. It really does speak to the cost involved in analyzing these tumors.
Let's call or a message from Barb Hopma. She asks, in what proportion of cases do you carry out PCR FISH or NGS? So the proportion of cases is really dependent on the tumor type. So certain tumors like a well-differentiated lipoma like liposarcoma, we would carry out in a high proportion of tumors, probably close to 80%, greater. In some tumors where there are no alterations, we won't necessarily do molecular analysis. But I would make a plea at this point to, when you are sending a case, could include a paraffin block at the same time. It would really just speed up the rate at which we can run a diagnosis, because the molecular analysis take a fair bit of time, and sometimes up to a week before we get that result. So if we have to call or request the block, that really just adds more time to the time diagnosis for these patients. A question from Barbara Popma. She said, do you have trouble with performing block on formalin-fixed embedded tissue? Probably not. I would say that when we went back and looked at our ability to the location, so when we extract RNA from paraffin-embedded tissue, which is generally would be the most finicky, we got over 95% efficacy in our extraction efficiency and ability to analyze those tumors. Sometimes the tumor amount is too small in terms of what's left in the block, and that turned out to be the more limiting factor than the formalin fixation. Are there fixations that don't work? For example, we've been just not successful in being able to do molecular analysis in tissues that are fixed in that fixative. Okay, great. No other.
Okay. If specimens that undergo decalcification, are you able to get any molecular analysis on those cases?
That's a good question. I was hoping nobody would ask.
All right.
That one is a bit more problematic, and that is, of course, why you asked that question. And that really amounts to the decalcification. So what's been used to decalcify the tissue, how long it's been in there, and what we're actually looking for in terms of an alteration. So, for example, if we were to do RT-PCR, if the product we're looking for is very small, then decalcification has less deleterious effects, assuming that it's been for a short period of time in a formic acid, a softer type of decalcification. We've been successful in getting an out of there. But generally speaking, decalcification has been much more problematic.
And additional question, not related to molecular this time, but how often do you use electron microscopy now for diagnosis of soft tissue tumors?
So we use it very rarely. And those guidelines, as you know, would have noticed, that started in 2009, which is how electron microscopy got on there. And I was just looking at numbers, and in the cases where we provided a secondary review or expert review, we had 4 cases of electron microscopy out of a total of 700. So less than 1%.
Over 1%.
Yeah. Less than 1%. So we do it really extremely rarely now.
Okay. Well, if there's no further questions, then on behalf of Cancer Cure Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I'd like to... Oh, there's a question?
No.
No, sorry. I'd like to thank Rita for a comprehensive and a very fair presentation, both on the synoptics and the handling of soft tissue tumors. This is the 4th session of the CCO-sponsored 2014 series of checklist presentations, and would welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Please feedback and suggestions as part of your completed online evaluations. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted by Cancer Cure Ontario, CPAC, and the Canadian Association of Pathologists. This recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for continuing education credits. You should see the session notice for more complete information. The certificates for each of these checklist sessions will only be issued for 1 month from the presentation date. The sessions will remain available for an undetermined period of time, but the certificates will only be issued for the 1 month, and refer to the session notice for the exact deadline date. To bring your attention to the next the education session schedule for 2014, which is occurring on Tuesday, April 1st, and that is pediatric patients with bone tumors.
No.
So again,
A question about the CME. It's Phoebe Shukri from Pathology at Markham Stouffville. If we attended and you have our email, would it be sent to us automatic or do we apply for it?
You have to submit the evaluation form, and then we send you the certificate.
What is that evaluation form?
I can send you a copy, but it would have been in all the information you would have received about this education session.
Yes,
Usually near the bottom of the notification.
Yes, that is true. And we did that before in head and neck and lung and so on, and we have much difficulty that we have to apply to oncology group rather than Cancer Care Ontario, the email we have. Much difficulty with that.
I see. No, I think there was some confusion because you had emailed another organization.
No, we emailed the one provided by Mr. Mazik, sorry.
Yes, yeah. If you complete the SurveyMonkey evaluation.
We had much difficulty.
Okay. Yeah.
Try to do that, and we'll see what happens this time.
Okay. Yeah. Nobody else is given a lot of feedback about it being difficult, so I'm not sure what kind of trouble you ran into, but generally it's pretty straightforward.
Okay then, and thank you, Rita. It's very good.
Okay. Thanks.